أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Management and complications of acute respiratory distress syndrome. First, the management. The essential aspects of management are to treat the precipitating cause, provide best supportive care with adequate oxygenation, and avoid further damage from barotrauma, hyperoxia, and nosocomial infections. Mechanical ventilation with positive end expiratory pressure, called PEEP, and higher inflation pressures are almost always required to maintain oxygenation. Saturation values in the low 19s are entirely adequate. There is evidence that the higher inflation pressures may worsen acute respiratory distress syndrome directly from microbarotrauma. Therefore, try to maintain plateau pressure below 30 centimeter water. Many ventilation strategies have been tried to reduce the high inflation pressures that result from the stiff lungs, which means low compliance. For example, using low tidal volume ventilation to reduce inflation pressures, that's to say 6 millimeter, 6 milli per kg ideal body weight compared with 12 ml per kg. Reduce the mortality by 9% and increase ventilation free days, and use of higher PEEP attempted to open collapsed alveoli has been shown in meta-analysis to improve oxygenation and is associated with lower intensive care unit mortality for patients with PaO2 over FiO2 below or equal to 200 millimeter mercury. Reducing the minute ventilation and allowing the PaCO2 to rise, which means permissive hypercapnia, also reduces the inflation pressures. Prone ventilation has been tried in attempt to improve vacuum mismatching, and initial increase in PaO2 are observed. A meta-analysis suggested a possible survival advantages for those with severe hypoxia, and a 2013 randomized controlled trial, ProSiva, has shown a significant reduction in both 28 and 90-day mortality for patients with severe acute respiratory distress syndrome. Although trial limitations prevent generalizations to all the patients. Several different artificial surfactants have been tried to attempt improving lung compliance, although good delivery to the abnormal areas is unlikely. Although effective in animal models, the randomized controlled trials have been negative in humans. Hemodynamic monitoring guided by central venous catheters has a similar efficacy to pulmonary artery catheter, but it is associated with having catheter related complications, which are mostly arrhythmias. Different degrees of hydration have been compared with reduced fluid balances, improving gas exchange, and shortening duration of mechanical ventilation. Secondary analysis for a cohort study suggested that a negative day for fluid balance is associated with decreased mortality, although this was not confirmed in a randomized study. High dose steroids have been used, but there is evidence of harm as well as benefit and minimal evidence of overall improved survival. Some ARDS related diseases, such as acute eosinophilic pneumonia, usually show good response to steroid therapy. A 2019 Cochrane review suggested that steroids may reduce early mortality but low certainty. No consistent evidence of difference to duration of ventilation or late mortality. Certain subgroups may do slightly better and others worse, e.g., steroids are possibly beneficial during the first 14 days but detrimental thereafter. Extracorporeal membrane oxygenation, CO2 removal, will buy time and allow the lung to rest, but these techniques are very expensive and it is difficult to demonstrate any long term benefit. The latest United Kingdom ARDS recommendations include the following items which strongly in favor include tidal volume below 6 ml per kg ideal body weight and plateau pressure below or equal to 30 centimeter H2O and the prone position for moderate or severe ARDS more than 12 hours. And weekly in favor include conservative fluid management, higher PEEP for moderate or severe ARDS, neuromuscular blockers for moderate severe ARDS using 48 hour of cisatracheum infusion and extracorporeal membrane oxygenation ECMO in severe ARDS, higher, higher lung injury score, or hypercapnic pH below 7.2. And recommendations inhaled vasodilators, weakly against inhaled vasodilators, and strongly against higher frequency oscillatory ventilation, HFOV. Complications of ARDS: the higher ventilation pressure leads to barotrauma, pneumothorax, surgical emphysema, pneumomediastinum, and pneumothorax may be lethal but difficult to detect on chest X-ray in the supine position. And nosocomial infection occur in about half of the patients, making surveillance many bronchoalveolar lavage is important. And the myopathy associated with long-term neuromuscular blockade and high use of steroids and poor glycemic control. Non-specific problems of venous thromboembolism, gastrointestinal hemorrhage, inadequate nutrition. Prognosis improved over the last 20 years, probably due to improvement in supportive care and ventilator strategy rather than an ability to modify the inflammatory process and its subsequent repair. Prognosis is worse with intrapulmonary causes, and early deaths are usually due to precipitating condition and later deaths to complications. Over half of the patients will survive with varying residual lung damage, although the pulmonary function tests (PFTs) often show only minor restrictive abnormalities and reduced KCO, indicating the considerable capacity of the lung to recover. A prospective cohort study showed that 6-minute walking distance remained decreased even at 5 years. That's all. Thank you.